So with that, Dr. Iyer.
Thank you, Merrill. Good morning to our distinguished panelists and distinguished guests. What I'd like to share with you this morning is specifically what we're doing in the realm of chronic disease management using health solutions, but specifically talk about the value proposition and what I believe the key success factors are for these solutions to become operationally mainstream and adopted by patients and by the clinical community. By way of background, I always start my presentations with the fact that I'm a wireless guy in my heart. I was in the wireless industry for 20 years. And then in 2002, I developed type 2 diabetes myself. And so I affectionately joke that here I am at WellDoc with the two things that define my DNA. One is good, which is wireless in my blood, and one is not so good, is too much sugar in my blood. But here we are at WellDoc. In any event, let me actually lay the groundwork on the problem we face. 7 out of 10 Americans suffer from at least one chronic condition. Chronic diseases are the primary cause of death and disability worldwide, certainly here in the US, but also worldwide statistic. If I use diabetes as an example, the direct cost of managing diabetes today in the United States is $218 billion. And that's $218 billion, which includes the cost of drugs, supplies, hospitalizations, et cetera. When you actually look at the complications that diabetes causes, blindness, kidney failure, amputations, heart attack, stroke, the actual cost of the combined effect of these complications, 1 out of 5 of our healthcare dollars, which is some $2+ trillion, goes to this spend. So it's a massive spend. The sad statistic, or perhaps the opportunity, if you're a cup is half full person, is that many of these complications can be avoided if the patient actually follows what their doctor's regimen is throughout the day. So when we actually look at the inception of WellDoc, we asked a very simple question. We saw patients coming into the clinic, and this was up at the Joslin Center, University of Maryland. And these patients, average patients, they have to manage their medications, they have to manage their exercise, diet, smoking, stress, sleep, all the things that affect their diabetes wellness. And there's this little thing called life that tends to get in the way every now and then, right? I consider myself a good patient. I write down everything. In fact, I graph it because I'm a little bit of a nerd and I take it into my doctor. But what's my doctor going to do in a 2-minute office visit? The human eye can only do that much pattern recognition, right? And of course, going and checking my blood glucose before I see the doctor is like flossing the day before you see your dentist, right? Your blood sugar is never as good as the day you see your doctor. It's always really good when you meet your doctor. And so it's a little bit of garbage in and garbage out.
We're going to give you a 10-minute visit.
So we asked a simple question in that everybody who came in to see the doctor, regardless of their socioeconomic status, had a cell phone. And they weren't afraid to use it. Excuse me, doc, I need to take this call. And the question was, could the cell phone actually become, not the solution, but could the cell phone become part of the solution that actually provided a coaching basis for the patient, to provide them the behavioral support, the coaching support that they needed to follow their doctor's regimen throughout the day? But could the system actually take that data that was being collected by the patient, and could it do two things? Could it first look at the longitudinal patterns? Why is this person consistently taking half of the amount of this drug? Or why are they consistently measuring high blood sugar values, say, after their lunch meals? So it looks at the patterns. And then the last thing was, could you take all of that data that was collected, run it through an evidence-based system, not through a human, but through a system, and have it map against evidence-based medicine to say, here's where the patient was, here's where the patient is today, this is what's changed. This is what you, the provider, may want to consider doing, but you're the expert, do what you think is right for your patient. And when we asked that question, we did so with 3 things in mind. A, would people use it? This is 2005, before the word app was part of our language and the iPhone existed. B, would doctors think we were stepping on their toes? Okay? Is it something that we were crossing a line, if you would? And of course, the third thing is, would it require the patient to be a BlackBerry junkie, tech savvy, high socioeconomic status? In that first clinical trial, there's a number in diabetes, some of you may know, called A1C. And A1C in simple English is the amount of sugar in your blood. It's a volumetric measure that says a percentage of your total blood volume is sugar. Now, the target, the ADA, American Diabetes Association target, is 7%. That means 7% of your blood volume is sugar in simplistic terms. Every 1-point delta, 7 to 8, 8 to 9, represents a 42% increase in the risk of heart attack, strokes, kidney failure, blindness, etc. The average A1C today in the 25 odd million people in the US today that have diabetes is 9.3. So you get a sense of how badly we're broken. In our clinical trial, we dropped A1C by 2 points. Now, the significance of that 2 points, you understand. A drug is heralded by the FDA if it drops A1C by a half a point. So when we got the 2-point reduction, people were calling us and saying, what are they doing, swallowing the cell phone? No, no, no. What they're doing is they're actually following what their doctor's been telling them to do, and they're avoiding these excursions, extreme highs, extreme lows. They're staying in range, they're following their regimens the way they should. The sister statistic to that was doctors that received that analysis were 5 times more likely to actually titrate a medication or make a medication modification to the patient. And so what we found was both adoption on the side of patients as well as adoption on the side of providers. Now, let me talk economics. There's a number of studies in the literature that show what the average value of a 1-point A1C drop is. And depending upon whether you drop from 11 to 10, 10 to 9, 9 to 8, of course, the costs vary. But on average, a 2-point reduction can be anywhere between $1,300 and $1,500 per patient per year, as high as $7,000 or $8,000 per patient per year, because you're dramatically reducing their excursions, which lead to adverse events, emergency room visits, hospitalizations, which Dr. Katz might address in his talk. And so what we found was in an OpEx model, we didn't start the company with $19 billion of HIT money. With an OpEx model, using the investments that are already being made by the wireless community and the devices that are accessible to people that they have with them all the time, we were making this kind of impact. And so when I think about the value proposition of this, and I think about extending that value proposition to whether it's asthma, whether it's congestive heart failure, whether it's COPD, oncology, every one of these chronic conditions requires medication management, symptom tracking, patient-physician communication, patient self-coaching, behavioral modification. If you can actually deliver, I mean, why is it that we have our own ringtones and we have our own screens and skins for our cell phones? Why can't I have my own chronic disease management messaging? We even adjust the tonality of the messages based on what the patient preferences are, because you want them to adopt it. You want them to not put this on the shelf after 3 months. You want them to sustain usage of these. That's how they get the sustained long-term benefit. So as I look towards what I believe is going to be required for these types of solutions to be mainstream, it's really 4 things. First and foremost, these have to have demonstrable outcomes. Otherwise, it's an app and it's a game. Nobody in the health system is going to adopt it, okay? It has to have clinical evidence that's blessed, if you would, by the clinical community. We just are going to publish in September in Diabetes Care a large trial with a randomized controlled trial study with Care First, Blue Cross Blue Shield of DC, Maryland, Virginia, a year-long study with a large sample size population where we got a 1.9 A1C reduction. Again, 3 to 4 times what you get from a blockbuster diabetes drug. So something that is sending a shockwave, if you would, through the diabetes community. So number 1, it has to have clinical outcomes. Number 2, and Meryl touched on this, it has to be done within the confines of the regulatory environment. When we first submitted for our 510K clearance with the FDA over a year ago, they didn't know what to do with us, because this piece of paper, this document wasn't in existence then. In fact, we helped create this document. And it's interesting because the FDA says, hey, wait a minute, you're using the phone as an accessory, if you would, to the blood glucose meter. They poke their finger, they enter a number. Well, that means the phone should become a regulated medical device. And then they asked us the logical question, well, are you going to put this on every phone, aren't you? We said, yes. Oh, well, then you'll have to just submit every phone. And we said, wait a minute. There's 4,000 phone models. We'll be spending the rest of our careers at WellDoc submitting to the FDA. And so we got them to the point that said, no, actually, you guys are really interested in managing and optimizing patient risk. You don't want to incur any additional risk to the patient. So we said, what if we create the argument that says there's only 3 types of handsets? There's a handset that has an alphanumeric keypad, and there's a certain risk profile with like typing a wrong number. There's a cell phone that has a QWERTY keyboard like a BlackBerry, and of course there's a touchscreen like an Android or an iPhone. And if we can show you that the same patient with the same 3 devices, with the same instructions, gets to the same place without incurring any incremental risk, would you buy that? They said, show us the proof. So we did the human factor study and showed them the proof. So what the FDA, a lot of people say, and it's interesting, you go to these wireless conferences and they're saying, how do we get around the FDA? No, how do you work with the FDA? Because they're actually taking, through efforts like this, they are taking and listening to the industry and saying, hey, how can we actually innovate within the confines of ensuring that we maximize and optimize patient safety? So number 2, check mark FDA. The third thing is accessibility. And accessibility has 2 vectors. One is socioeconomic accessibility. I can't force somebody to buy an iPhone. That's the only way it can be used. This works on a good old flip phone, Nokia phone that they still have here in the US and elsewhere. So it's got to be multiple device, multiple operating system, and multiple network. So when you look at the likes of AT&T, when you think about AT&T as a hub that provides WellDoc-like services in a scalable, secure, HIPAA-protected, encrypted manner, that's not our core business. So it's therefore incumbent upon people like WellDoc to collaborate with people like AT&T, because in many ways I get to stand on L's shoulders because I can reach higher. I couldn't do what I do without their help because I don't have the breadth of their network. I don't have the breadth of their encryption and their hosting and multi-platform capabilities. So accessibility is multiple device network and operating system, and it's also socioeconomic. As Dr. Katz will probably address in some of the work that he's done with the DC Connect Health Project in the Medicaid population with very, very simple, not smartphones. This is something that should work in a very low-cost manner. We're making a profound difference in outcomes with the technologies that people have at a very low cost. The last thing is, of course, clinical integrability. We have always maintained that such solutions have to be integrated into clinical workflow, into clinical practice, and into the clinical systems. Everybody, courtesy of meaningful use and its mandates, are implementing the electronification of systems. You can't get an underpaid, overworked doctor to go to two places. They're not going to go to Allscripts, McKesson, and then go to WellDoc. They'll never do it. And then you've just killed the value proposition. So it's incumbent upon us to make sure that we integrate into the systems that they already are using or that they will be using, courtesy of the mandates coming from meaningful use. And so with those four principles of outcomes, regulatory approval, accessibility, and clinical integrability, if we can do those four things, which we're doing today, and we're doing it with real plans and real payers, we can continue to make a significant dent in the costs that we incur in this country and certainly elsewhere in the world, and dramatically improve outcomes to levels that aren't achievable by drugs alone. Thank you.
Thank you.